We already know dysphagia means difficulty with swallowing. Depending on the time of onset, dysphagia is of two types: oropharyngeal dysphagia, esophageal dysphagia. If difficulty with swallowing happens immediately after swallow, then it is oropharyngeal dysphagia. If it happens after few seconds of initiating swallowing, then it is esophageal dysphagia. We have already discussed oropharyngeal dysphagia. Now coming to esophageal dysphagia. In esophageal dysphagia, we will ask if the symptom is related mainly to solid food or it is mainly to liquid food. If it is a predominantly solid kind of dysphagia, then it is structural in nature. If it is a liquid kind of dysphagia, predominantly liquid, then it is functional in nature. The structural entities of esophageal dysphagia can be due to esophageal structure or mass. Functional entities of esophageal dysphagia include motility disorder of the esophagus. Now let us see some cases related to esophageal dysphagia. This is a 40-year-old female with a dysphagia. This is the barium esophagogram image. In this, we see there is a membranous narrowing in the esophagus. This membranous narrowing is known as the web. Because it is located below the cricoid, it is known as post-cricoid web. Post-cricoid web usually seen in the setting of Plummer-Vinson syndrome. Plummer-Vinson syndrome includes a triad of post-cricoid wave, iron deficiency anemia, and koilonychia. Iron deficiency anemia is a microcytic hypochromic anemia. Koilonychia refers to spoon-shaped nails. These triads come under Plummer-Vinson syndrome. This syndrome is important because it is a risk factor for development of squamous cell carcinoma of esophagus. This syndrome is also known as Patterson-Brown-Kelly syndrome. Another condition similar to post-cricoid web that causes esophageal dysphagia is Skarsky ring. It is a circular ring that is located at the level of the gastroesophageal junctions. It usually corresponds to the squamo-columnar junction, also referred as the B ring. This is often asymptomatic. It becomes symptomatic if the caliber of the esophagus becomes lesser than 13 mm. We discuss rings and waves of the esophagus. These two are quite uncommon condition of the esophagus. Now coming to a common condition of the esophagus, which is known as gastroesophageal reflux disease. This condition usually most commonly presents with heartburn. Heartburn refers to a burning sensation behind the sternum. This symptom usually mimics the chest pain of acute coronary syndrome, which need to be differentiated. Another symptom of gastroesophageal reflux disease is regurgitation. Regurgitation refers to the effortless return of food into the pharynx without any nausea. The etiology for gastroesophageal reflux disease lies in the laxity of lower esophageal sphincter. Lower esophageal sphincter, we already know, is a functional sphincter. Its mechanism depends on three factors. One is acute angle entry of esophagus into the gastric lumen. Second is intra-abdominal pressure, which compresses the esophagus. Third, the diaphragmatic thrust, which acts on the lower part of the esophagus, creating a pinch cock mechanism. Commonly, three factors are responsible for GERD. One is transient lower esophageal sphincter relaxations. This is the most common factor that is responsible for GERD. Second one is the lower esophageal sphincter hypotension. Third one is the anatomic distortion of the gastroesophageal junctions. Anatomic distortion happens when the GE junction migrates through the esophageal hiatus into the thoracic cavity. Because of the upward migration of the GE junctions, the lower esophageal sphincter mechanism often fails. That leads to reflux of gastric content into the esophagus. The diagnosis of GERD is presumed from the symptom of heartburn and regurgitation of acidic gastric content into the pharynx. Once the diagnosis is presumed, the patients were started with empiric therapy with proton pump inhibitors. Proton pump inhibitors are the drug of choice for GERD. Often the patients tolerate well to proton pump inhibitors. In some cases where the diagnosis is in doubt, 24-hour pH monitoring is done to confirm the diagnosis of GERD. In these, a catheter is passed from the nose into the esophageal lumen and pH is continuously monitored. Once the pH is found to be less than 4, then the diagnosis of GERD is confirmed. Commonly encountered complications of GERD are reflux esophagitis, Barrett metaplasia, and development of esophageal adenocarcinoma. Reflux esophagitis happens because of irritation by the acidic gastric content. Recurrent irritation of the esophageal squamous mucosa leads to conversion of the squamous mucosa into columnar intestinal metaplasia. This is known as the Barrett metaplasia. Barrett metaplasia, seen on endoscopy as salmon pink color. The salmon pink color usually seen in the gastric mucosa. ascent of the salmon pink color into the pale esophageal lumen suggests presence of Barrett metaplasia. Barrett metaplasia is a pre-malignant condition. It often predisposes for development of esophageal adenocarcinoma. Commonly, the most common variety of malignancy in esophagus is squamous in nature, squamous cell carcinoma. However, in Barrett metaplasia, there is a predilection for development of adenocarcinoma because of the conversion into columnar epithelium. The management of GERD depends on patient's symptoms. Often patients started with empiric proton pump inhibitor. Proton pump inhibitors are the drug of choice, and patients do well with the proton pump inhibitors. If patient gets symptomatic relief with proton pump inhibitors, then a gradual step down approach is taken, where the dose of proton pump inhibitor gradually tapered to the minimum and then withdrawn. If the patient fails to medical management, then surgical approaches are adhered. The surgical management options are anti-reflux surgery. The purpose of anti-reflux surgery is to strengthen the lower part of the esophagus, that means the abdominal part of the esophagus. It is strengthened with a wrap of stomach around the lower part of the esophagus. This surgery is known as fundoplication surgery. Fundoplication prevents the reflux of acidic gastric content into the esophagus. There are three different types of fundoplication surgery described. One is total fundoplications, where the wrap covers all around the esophagus. This is described by Nielsen, that is why it is known as Nielsen's fundoplication. Other two are partial fundoplications, because anterior or posterior part of the esophagus remain open. If the posterior part of the esophagus is fully covered, then it is known as posterior fundoplication, described by Tope fundoplication. If the anterior part of the esophagus is covered, then it is known as anterior fundoplication, described by Dore. Coming to today's learning, we understood that dysphagia to liquids predominantly, in addition to solid, points in favor of motility disorder of the esophagus. Plummer-Vinson syndrome occurs in a Middle East female with triad of features like post-cricoid esophageal web, iron deficiency, anemia, and colonacia. Plummer-Vinson syndrome, we understood that increased risk of squamous cell carcinoma of esophagus. Most common symptom of GERD is heartburn, that is burning sensation behind the sternum. It happens due to transient lower esophageal sphincter relaxation. Squamous to columnar metaplasia of esophagus is known as Barrett esophagus. A CETL protocol is used for endoscopic sampling of Barrett esophagus, and it has a tendency for development into adenocarcinoma of esophagus. Proton pump inhibitors are the empiric drug of choice for GERD. Fundoplication is the recommended surgical options, and there are three different kinds of fundoplication surgery described.